Hello, my name is Tor Ulla. I'm a certified hand therapist at Commonwealth Hand Therapy in Lexington, Kentucky. And today I'll be presenting a case study on distal radius fracture. And I'll be talking to you about one of my current patients. I've been working with her for the past few months and get started. All right, so my patient was injured initially January 4th of this year. She was struck by a car while crossing a road. She sustained a distal radius fracture, Colles fracture, pelvic fractures. She also had a bad contusion on her head. So a Colles fracture usually ends up with a dinner fork deformity. So that's a volar apex and dorsal displacement of the radius. She was initially treated conservatively, so she just was casted. The patient herself, she's a 76-year-old right-hand dominant female. She's retired, enjoys gardening, reading, traveling, visiting her grandchildren. She does have some complicating factors of arthritis and osteoporosis. And she has strong support from her husband, and she has an overall very good attitude. Even from the first visit when I met her, she's kind of laughing and jovial about it, and she called her hand a dolphin hand. So that's why I have the dolphin picture here. So she's a very nice lady, but she has a really bad fracture. All right, so fast forward 6 weeks from there, so bring us to February 19th, 2020. Patient was referred to a hand surgeon due to the fracture not healing well. She was left with too much dorsal angulation of the bone, and she had lost a lot of height in her radius. So the conservative measure had failed, and so the hand surgeon was called in, and they diagnosed a left distal radius malunion requiring open reduction and internal fixations with volar and dorsal plates and PIN neurectomy. So the PIN was excised at the wrist because that's the nerve that gives sensation to the wrist. So they're trying to reduce pain later on. Another thing with the volar and dorsal plates, initially the doctor was only going to do a volar plate, but due to the osteoporosis, the patient required a dorsal plate as well because the screws were actually going all the way through because of the soft bone. So I thought I'd add this in because it's interesting. When I first saw the script for the patient, it just said finger exercises and edema control for a left distal radius fracture. So it seemed pretty unassuming. We see a lot of distal radius fractures at the clinic, and I thought this was just going to be another one, but it was quite a bit more than we had anticipated. The patient was, I guess, a very severe distal radius fracture, and it was not the ordinary. So if we look at the x-ray before and after surgery, the left is before and the right is after, obviously, but you can see the change in height of the radius, which actually lifts the carpal bones, gives them better glide and roll, but also gives more tension to all the tendons that pass the wrist. Before, there's a lot of slack put in them because there's just lack of height. Also, the second point is the tilt of the radius, and I'll go show a picture here. So it was a dorsal tilt before, but they reestablished a better tilt, so the radius and the carpal bones were able to glide a lot easier now. So she did a very good job with that, and also improved thumb stability through increasing the carpal height or the radius height. So very good surgery and gave her a chance at actually recovering. All right, so move on to my initial evaluation with my patient. This is 6 weeks status post-surgery. So if you think about it, she was conservatively treated for 6 weeks in a cast and then 6 more weeks in a cast after surgery. So we're already 12 weeks out from her injury. So it's a long time. She's got a very stiff wrist. We've got 55 degrees of volar flexion and negative 45 degrees of dorsiflexion. So she only had 10 degrees of motion. The wrist was contracted forward. Fingers were very stiff. We had a 30% fist, 10% hook. Metacarpals, not terrible. Passively, we get them down to about 80, which is a good position. But we did want to improve that. And her dash was 75, indicating a lot of problems with her ADLs at home. So I identified her major limiting factors from the beginning as trying to change her hand from an open pack position to a closed pack position, which is getting the wrist back, getting the metacarpals down, and maintaining digit extension. She also had severe intrinsic tightness from lack of motion from her FDP and being left in a poor position for a long period of time. So that's going to limit her grip and overall function of her hand. So we're going to address that. And also a lot of scar adhesions. So whenever she had her surgery, you can imagine all the FDP tendons and FDS tendons and the wrist flexors, but also all the extensor tendons on the back, since she had a dorsal plate as well. They're all at risk for developing scar adhesions from the blood and the scar forming in that area. So we had to work diligently to address that. All right, next up, I want to talk about the pathophysiology of her injury. First thing was the grasp reflex that she did not have due to the position of her wrist. So her wrist was stuck in a position of being flexed forward. So if there's no grasp reflex, which means being able to extend your wrist back, open your digits, and grasp, there's very low functional use of the hand, so we're going to try and reestablish that. Also, she had a lot of adaptive shortening due to the position of her hand being in. The picture on the left shows a good example of almost exactly what it looked like. The wrist flexed forward. Without stress, tissue will shorten to a position that it's sitting in, and usually a wrist will extend and flex and the fingers will move, but hers was stuck, so all the tissues actually got shorter, including all the tendons, ligaments, and also the nerves can get short as well. So she was having a lot of pain when we were working with her and trying to extend her. We kind of talked about this before, but all the tendons gliding over the scar where they put the plate in. This picture shows a good example of how the tendons sit right across where the fracture is and how they can be exposed to tendon adhesions. And also, she had a lot of autonomic flare. So her hand was swollen, it was red, painful just with gentle stress. If I touch it or give a little bit of passive motion, she would kind of jump out of her seat. So we needed to treat that as well. We didn't want this to turn into something like a CRPS type situation. So the plan, first things is get her into a custom orthotic to control her wrist, to protect the fracture that was still healing, and keep her wrist in a good position. So first one was going to be just a wrist gauntlet to try and get her wrist back into some form of extension. I believe the first day I was able to work with her enough just through manual treatment and heat, get her into about +10 in her wrist, and then we were able to adjust the splint later on as needed. Edema pain control, This goes along with the autonomic flare. So for edema control, we use a lot of Coban wraps on the fingers and the palms. We use compression sleeves, compression gloves, things like that. So compression is really important. We use a lot of TENS to help with the nerve and calm it down because it's kind of in an excited state. And it allows the patients to move a little easier in therapy. Edema control. We do pain control through modalities such as paraffin. We do stress loading programs, which include scrubbing and bucket carrying, though they need their bone to be healed. And then we use activities that are graded enough to allow them to move their hand, which will help flush out swelling and pain chemicals as well. So that's where the motion comes into play. A really big part of that with moving your hand when it hasn't been moving for a long time is fluid shift. And in each of the joints, there's synovial fluid that usually gets pushed back and forth through normal joint kinematics. But when it's not there, the fluid kind of builds up in areas and becomes a little more viscous. And your body doesn't produce as much of the synovial fluid. So motion will help create more of the fluid and shift it and help with glide of the joint. So you need to kind of continue these at all times, do them all over again. We did them for months and months and months. You can get a bit monotonous, but it does help, and you just have to be very consistent and keep on top of it. All right. Next up, muscle balancing. That was just going to include a lot of stretching of the extrinsics and intrinsics. Later on, using splints to do that. But initially, a lot of manual exercises, but also home exercise programs that I wanted to do all the time. Scar treatment, so that included an elastomer pad to help with the scar that had formed and to stop any more scar synthesis from occurring. It's elastomer made of silicone, and we formed that on the patient's scars. And then creating a home exercise program that she felt confident she could do, but also be effective and give her an edge while doing a lot of exercise at home. I anticipated we'd see her 2 to 3 times a week, 4 to 6 months. And the goal was to get her physical demand level from sedentary, which it was at the initial eval, to light, because she is retired. She doesn't have a lot of heavy duties. So we just want to get her back to being able to, cook, clean, eat a meal, and kind of do some light gardening. All right, so we fast forward onto the treatment. We got 3 phases of treatment. Phase 1 was the first 2-3 weeks. She's still in an inflammatory phase and kind of healing phase. She had a lot of pain and swelling still, so we were really focused on reducing the autonomic flare through all the things I talked about earlier: TENS, paraffin, and stretching. And then we were working on a lot of passive range of motion, ready her for corrective splinting, which is going to be a big part of her treatment later on in this. We did have to wait for the bone to fully heal and get an okay from the doctor first. The other big thing was we had to build her confidence up because she had very low confidence that her hand was actually going to get any better. So giving her activities that she could do and grade them to the appropriate level made a big difference. And her actually seeing that her hand was useful and able to do something did a lot with the buy-in for therapy. And I think it's a really important point, especially at the beginning. If you can build a good relationship of trust with your patient, the whole experience is going to be better for everybody along the way. And she missed very few visits, maybe 2 or 3 for the whole past 3 or 4 months. And she's always excited to come in therapy and see her hand get better. So phase 2, approximately 8 to 12 weeks status post-surgery. We worked on strengthening. So we were doing some some grip and holds. We're doing some putty, you know, trying to get her tendons to glide through the scar, trying to get the muscle built up again. We're continuing all the pain and edema control techniques that we talked about earlier. We're just adding on to it now. But the biggest part of this phase is the corrective splinting. So first one we have here is a MCP flexion splint. I built that onto the gauntlet that she already had. You have the fin down here, connects to P1 on the fingers, and it's a static progressive, so you can slowly work it down. Also have a thumb piece because she had a very tight web space, FPL. And we were actually able to adjust this fin as her metacarpals got a little more flexible. So, and then we added on a alpha strap here across P2 and 3 to help with the composite flexion. Next up, so this is a intrinsic stretch splint. The metacarpals are at a slight hyperextension, and PIP and DIP are at max flexion, which is the way to stretch the intrinsic muscles. She would wear this for about an hour on, hour off, same as the MCP flexion splint, throughout the day to try and change the length of the tissue. What you got to do is a slow stretch, gentle stretch for a long duration. So made a big difference in her grip and the motion of her hand. And then to address the web space a little more, I made her a C-bar, the black one here on the left, that she was wearing at night. And I would slowly work that out as she would gain a little more motion in her web space. And then whenever we got enough, I put her in a hand-based thumb spica to maintain that web space, but also give her more function. She did have some arthritis in the base of her thumb. It was a bit painful, so we were able to protect that while at the same time maintaining the web space. All right, so this is not a picture of her, but kind of represents, we're just focusing all our energy on that one arm, trying to build it up again. Hopefully not that big, so that would be weird. Here's her progress. After 6 visits, she had just entered the second phase. So we got her wrist moving from 35 to 5 degrees. So she was getting about 40 degrees of motion. Her fist was 50%, hook was 50%, and we got some good motion from her MCP joints. And her dash went down a significant amount, down to 39. So 75 to 39 indicates she's using her hand a lot more at home and a lot more functional. So she was pretty happy, and her pain and her swelling was down as well. So go to phase 3, which is what we're still in now. This plan is to just kind of continue to progress strengthening. We're going to keep adjusting the orthotics to maintain a gentle stretch, but still stressing the tissue and working towards the goal of increased strength. We don't have any really advanced goals, such as getting her back to a factory or working on cars. So we don't have to think about getting her physical demand level to a medium or a heavy or very heavy. So just getting her hand a little stronger is going to be the key for her. So the results of all this, currently we're 25 weeks out, status post-surgery. We've had 36 therapy visits. Her fist is 95%. Her hook is 80%. Got some pictures here. So got good motion of her fingers, got good extension. Her wrist is moving 50 degrees of flexion and 55 degrees of extension, which is a great outcome for any distal radius fracture. And her muscle length is good too. As you can see here, she's moving like a champ, back and forth. Her grip, 56 versus 32, so it's improving, still not quite where we want it to be, so that's why she's still in therapy. We're really focusing on strengthening now. The pinches are a little weak as well. Just trying to get her back to, getting in the garden, doing her chores, things like that. And you can see here, her thumb is moving really well too. Her dash right now is an 18, which is a win for us. I don't anticipate it to get honestly much better. If we discharge today, I'd be happy with that number. That's about it. Kind of quick little presentation on what we did with her. I think it was a really good outcome. She worked really hard, but I think the biggest thing was we had a really good doctor on her side that fixed her up. So if you have any questions, please let me know.